Dr. Suraj, are you with us?
Good evening, sir. Yes, sir. Sir, I am unable to upload my PPT, sir, in this app.
Your slides.
Yes, sir.
I am
Sir?
able to see your slide.
Yes, sir.
Good.
I am not able to. Yes, sir.
Please share your PowerPoint. You just now unshare. Please share the PowerPoint
Okay, sir.
screen. Please switch on your video first.
Yes, sir.
All right. Now share your screen and open the PowerPoint.
Yes.
Your connection is good, right?
Yes, sir. Sir, is it
Go to the
visible?
first slide. Go to the first slide. Make it full screen. Right. Remain like that. Warm
Yes.
welcome. Good evening, friends. Warm welcome to all of you. Today we have yet another important session of the postgraduate clinics. In fact, today we are in the 342nd section of postgraduate clinics, which has been happening. We have a very eminent faculty. Professor Amit Gupta should be joining shortly. Professor Karnakaran from SRM Trichy. Professor Hemant Natyal from Himalayan Institute, Jaligrant. Professor Peripheral and Professor Patreshwara, both are from NHL Medical College, Ahmedabad. So the candidates are kindly contributed by Professor Srimakana ma'am at IMS PHU. Dr. Suraj will be presenting first, and Dr. Malini Manavalan is from Chengalpet Medical College, kindly contributed Professor VT Arasu. So today we have two cases, one on right leg fossa mass abdomen, the other one is a peripheral vascular disease. So ladies and gentlemen, warmly welcome all of you, and I request the faculty to kindly take over and take care of the proceedings. Good luck to you, candidates. Dr. Suraj, please introduce
Yes.
yourself, your unit chief, your head of the department, and start your presentation. Good luck to you.
Yes, sir. Good evening, respected teachers. Sir, I am presenting a case of 35 years female homemaker resident of Gazipur belonging to lower middle socioeconomic status presented to OPD with chief complaint of pain in the right lower abdomen for 8 days, fever for 8 days. She was apparently asymptomatic 8 days back when she developed pain which was acute in onset, gradually progressing moderate to severe in intensity. It was initially localized to periumbilical region, which later shifted to right lower abdomen, associated with nausea, non-radiating, non-referred, partially relieved with oral analgesic, no aggravating factor. The patient also complained of intermittent fever for 8 days, not associated with chills and rigors or diurnal variation. Patient initially went to a private hospital in Mau, where he received medication, but not relieved, referred to BHU. There is no history of vomiting, hematemesis, abdominal distension, altered bowel habits, yellowish discoloration of eyes and urine, melena, hematochezia, rectal bleed, urinary complaint, and no history of any trauma or chronic drug intake. Past history, patient is a history of hysterectomy at Pandit Dindayal Upadhyay Government Hospital in Varanasi in 2018. There is no known comorbidities. Family history not significant. Menstrual history and obstetric history. Minarch at 13 years of age with regular cycle, normal flow. Patient post hysterectomy status with P2 L2 post full term normal vaginal delivery. So personal history, patient is on mixed diet with normal bladder bowel habit with normal sleep pattern. Patient is history of chronic tobacco addiction for 15 years. No known allergies. On general examination, patient conscious, cooperative, and oriented to time, place, and person.
Wait,
Afebrile.
wait, wait. Wait.
Yes, sir.
Yeah, let's go to yes, sir, please. Dr.
Yes, sir.
Kirit.
Yeah, yeah. We'll go to first slide.
Yes, sir.
Next slide. What type of pain it was? Previous slide, previous slide.
Yes, sir. Sir,
You
it
said
was
acute pain, gradually progressive.
Yes, sir.
What
Sir,
was the type of pain?
Sir, it is a type of colicky pain, sir, which is initially localized to periumbilical region, which later shifted to right lower abdomen, associated with nausea. It is acute in onset, moderate to severe in intensity.
So you haven't mentioned it was a colicky type of pain.
Yes, yes, sir. Yes, sir. I will mention.
Yes. Any other? See, there is some
Second one.
network issue on my side.
Okay, Dr. Sahu. Next slide,
Yes,
please.
sir.
No, is there any associated uh, bowel or urinary complaints with this
No,
patient?
sir. Sir, though is no altered bowel and bladder, sir. Bowel bladder habits are normal, sir. No abdominal disease or altered bowel habits, sir.
No altered bowel habits
No abdominal
and
disease,
no.
sir. Yes.
Okay.
Sir, there is no history of non-passage of flatus stance stool, sir.
Why do you take history of yellow discoloration of urine? You think the patient is
Yes.
having jaundice?
Yes.
Yes, sir.
In
Sorry, sir.
pain right iliac fossa, why do you think the patient could be having jaundice?
Sir, just to root out, sir, hepatobiliary system, sir.
No, can hepatobiliary. So
Yes.
we have to. We can't. You will be ruling out hepatobiliary in say pregnancy also. Then है ना? Is there any
Yes.
connection between jaundice and
N-
pain right iliac fossa?
No, sir.
Why can there be thrombophlebitis? Pyophlebitis, portal pyemia leading
Sir,
to jaundice. Can there be? What is portal pyemia? Hello,
yes, sir.
what is portal pyemia?
Sorry, sir. I don't know.
It is uh, infection spreading through the portal vein to the liver.
Yes,
It can cause liver access, can cause cholangitis, uh, right?
yes, sir.
Okay, what about melena hepatochezia? Why do you take that history?
Sir, it is mainly for, sir, in sir, Crohn's disease. It can present, sir, melena, sir, in upper GI, sir.
Hmm?
Any, sir, same,
Crohn's
sir.
disease. Anything else?
Right.
Any other reason why you've taken? What?
Yes,
Suppose there was melena or bleeding per rectum or hematochezia. What would that
sir.
have told you?
Sir,
What
it
would your
can,
diagnosis be?
sir, we will more think toward carcinoma of cecum, yes, sir. Sir, more disease like chronic diseases like, sir, chronic Crohn's disease, yes, sir.
Patient is
Okay.
35-year-old female. You are suspecting malignancy. What sir want to ask, you just understand.
Yes, sir.
Common things occur commonly. Just think of the common things. Why you ask for chronic drug intake?
Yeah, sir. Sir, in case of, sir, in chronic drug intake, maybe, sir, intake peptic perforation can cause, sir, which can present as acute pain.
No, no, come again. Perforation because of drug intake causing this
Sir,
kind of pain in right iliac fossa.
yes, sir, mainly, sir, acute pain, sir.
But don't forget that sir is asking pain in right iliac fossa. Then you are suspecting peptic. Was the pain in, as you said that there were no aggravating factors. What was the relation of pain with the food? Was patient able to take food?
Sir, pain is, sir, sir, on, sir, patient complaint of nausea, but pain is not increasing after intake of food, sir. So there is no relation
So
with, sir,
that
food
means
intake.
patient was able to take food
Sir, due to nausea, sir, she is unable to take food, sir.
due to nausea. Okay. 。 . 。 。 。 。 。 。 。 。 . 。 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 。 . 。 。 。 。 。 . 。 。 . 。 。 . 。 。 . 。 。 . 。 。 . 。 . 。 . 。
Sir,
Yeah, next slide, please.
Yeah, next slide.
Hysterectomy, no con. Okay, next.
Next. Previous menstrual history. Okay,
Okay.
next. Previous. Personal history. History of chronic tobacco addiction since 15 years. Can you tell the
Yes, sir.
details? Tobacco in different forms can cause different diseases,
Yes,
right?
sir. Sir, in form of sir toothpaste of sir tobacco, sir Gulmanjan, he said about sir tobacco toothpaste, sir. He's taking for 15 years, sir.
For 15 years
She's taking in form of sir toothpaste, sir, during morning, sir.
during morning.
Yes,
Okay, Dr. Suraj,
yes, sir.
I just remembered you said about chronic drug causing peptic ulcer syndrome, right? Or
Sir,
perforation.
NSIDES,
Huh?
sir. Sir,
And NSAID.
NSIDES.
Okay. So, do you know what is Valentino syndrome?
Yes, sir. Sorry, sir.
Have you heard of Valentino syndrome?
No,
Have you
sir.
heard of
Sorry,
it?
sir.
No. Right. Valentino was a film actor in New York,
Yes, sir.
and he had a peptic ulcer perforation, and the contents went and collected in the right iliac fossa. And the doctors in New York thought it was appendicitis, and they removed his appendix. And the patient died of perforation.
Yes, yes,
Right. So this is Valentino syndrome.
yes, sir.
Okay. Right.
Yes, sir.
So peptic ulcer can be is a differential diagnosis
Yes, sir. Appendicitis.
of appendicitis.
Right.
Okay. Next slide, please.
So before
Okay.
general examination, at the end of your history, can you tell the differential diagnosis?
So since patient have sir pain in right lower abdomen with nausea and intermittent fever, so my diagnosis may be sir acute appendicitis. Sir, since female is 35 years, so sir any tubovarian mass, sir, maybe sir torsion of ovaries cyst.
No, no. Okay. Let's have your what are your positive findings? Pain right iliac fossa with fever.
Yes, sir. With intermittent fever and associated with nausea. Yes, sir.
Why not
Have
any
you
inflammatory bowel condition?
No, sir. She is not complaining of any, sir.
okay? So you said one is appendicitis. What is the other one you said?
Sir, torsion of ovarian cysts. Sir,
Torsion of
one is sir,
ovarian cyst,
ileocecal
torsion
TB,
of
sir.
ovarian, and ileocecal tuberculosis.
Yes, sir.
Anything else?
Sir, psoas sepsis can be.
Okay. So what's up? Is anything else? No malignancies.
Sir, since sir young carcinoma cecum may be suspected in trilateral fossa, sir. But young
It's
age
in
is
the
sir
again,
risk.
but it can happen. That would be
Yes,
last very low down.
yes, sir. Yes, sir.
Okay. What about PID? Have you taken history of
Sir,
discharge? Oh, she doesn't have a uterus. Fine.
no,
Okay.
sir. No step, sir. Per vaginal bleed, sir. No step any PV discharge, sir. Per vaginal discharge, sir.
Hysterectomy has been done. Okay.
Yes, I
Okay.
stated. Yes,
Okay. So should we continue with the examination?
yes.
Yes, sir, please.
Sir, patient is examined in late room after informed consent. Patient conscious, cooperative, and oriented to time, place, and person with afebrile pulse rate 80 beats per meter, normo-vulmic, normo-rhythmic, no radiofemoral delay, with blood pressure 114 by 74 in supine position right arm, with respiratory 16 per minute. Pallor present. There is no extraneous clubbing cyanosis, generalized improvement in pedal edema. Patient with weight of 56 kg, height 148 centimeter, with BMI of 25.5 kg. Sir, on examination of abdomen, sir, on inspection, abdomen is a flabby, umbilicus, centry placed and inverted, all quadrants moving proportionately with respiration. Fullness seen in right iliac fossa, a vertical scar mark approx 12 centimeter present below umbilicus in midline. up umbilicus to 2 centimeter above the pubic symphysis. Stria mark notice. There is no engorged vein, visible peristalsis and pulsation seen. So this is about slide up, sir. That patient.
Yeah, go
On palpation, yes, sir.
Yeah, go on. Continue.
Yes. Sir, on palpation, the localized of temperature present in right iliac fossa with tenderness present. A lump of size 5 into 4 centimeter noted in right iliac fossa, which is tender on palpation. Lump is firm in consistency, smooth surface, irregular margins. No pulsation noted over the lump. No other palpable organomegaly. All hernia site intact. On distal rectal examination, perianal skin normal, anal tone normal, fecal stain present. No blood on gloved fingers and no mass and abnormality felt. So on percussion, there is no evidence of fluid collection in the abdomen. On auscultation, normal bowel sound hurts, no bruise and hum heard over the lumps or elsewhere. So systemic examination are within normal limits. Sir, a 35 years female with chief complaint of pain in right lower abdomen, acute in onset, moderate to severe in intensity, associated with intermittent fever for 8 days. On examination, single lump of size 5 into 4 centimeter, noted right iliac fossa, which is tender on palpation. Lump is firm in consistency with a smooth margin with irregular surface, surface with irregular margins. So, based on my progener diagnosis, appendicular lump with differential diagnosis of ileocecal TB, tubo-ovarian mass, and last carcinoma.
So let's just go back to your summary. No summary. Summary.
Yes,
Summary. Pain since how long?
8 days.
Pain and fever both since 8 days.
Yes, sir.
And no other features, no vomiting, no
No,
loss
sir.
of
It was
appetite.
associated with nausea, sir. There is no history of loss of appetite.
But you've not written it.
Yes, sir.
Is nausea important here?
So I missed, sir. It was associated with nausea, sir.
Right. And no loss of appetite.
Yes, sir. No loss of appetite.
So you have to write. If you're making a diagnosis of appendicular lump, you have to give me all the symptoms of appendicitis.
Sir,
Right?
sir, yes, sir. Sir, appendicitis, sir, initially it's a pain, which is, sir, pain associated with vomiting and fever. Sir, generalized, these
Did
are
you
the
elicit the shifting of pain in your history?
Yes, sir.
Did you elicit the history of shifting of pain?
Yes, sir. There is history of, sir. Initially, yes, sir. In my history, there is
So
history.
that is important. No? That is important in your summary has to have
Yes,
all
sir.
the positive points which should don't go back.
Okay, okay, sir. Okay, sir. So it was initially the pain in periumbilical lesion which shifted to right iliac fossa, sir.
So
Right.
that's in all those criteria for diagnosing appendicitis. This is one of the major criteria.
Yes, sir. Yes, sir. It
You
should
have
be
to
added.
mention it in your summary.
Yes, sir.
Okay,
Okay,
let's
sir.
go back to your
We are not
to your
mentioned
summary.
where is the lump arising. Is it an intra-abdominal mass?
Right.
Or
That
a
is the most
retroperitoneal?
important thing I want to ask. You have not elicited the plane of the lump.
Plane of the swelling.
Yes, sir. So it is an intra-abdominal lump, sir. Yes, sir.
How do you know it's
You are not
intra-abdominal?
told it.
Yes, sir.
How do you know it's intra-abdominal? What test have you done to elicit it's intra-abdominal?
Sir, on leg raising test, sir, parietal are more visible, sir.
Now, what happened to this lump?
Yes, sir. It is not increasing, sir, on leg raising test.
Is it intra-abdominal means is it intraperitoneal or retroperitoneal?
So it is intraperitoneal, sir.
How did you look for it? You didn't mention it, pa.
Yes, sir.
You can
How
get a
do you know it's intraperitoneal,
retroperitoneal
not
swelling
retroperitoneal?
also in the right iliac fossa mass.
Yes, sir.
Did you look for the plane of the swelling? They should have mentioned it. It's an intra-abdominal, intraperitoneal. How do you differentiate between intraperitoneal and retroperitoneal mass?
Sir, retroperitoneal, sir, mass are generally not moving with respiration, sir.
So you think this one is moving with respiration?
Yes, sir.
You are not mentioned that also. Does
Yes, sir. I
moves
should.
with
Yes, sir. I
respiration.
should.
Now, how do you differentiate any swelling if it doesn't move with respiration? How do you differentiate between an intraperitoneal and a retroperitoneal mass? What was the previous teaching? Now, what is the teaching? What is the position you put the patient which are retroperitoneal. Now
Yes,
it has not been done. Previously, that knee elbow position was done
yes,
to differentiate. If it falls forward, it's an intra-abdominal. It was a retroperitoneal. Now they are not doing it. They do the shift test. Ask the patient
yes,
to turn to the opposite side. If the mass moves, it's an intra-abdominal. If the mass
yes,
is in the same position, it's a retroperitoneal. That is
yes.
very important. The plane of the swelling is very important. Can you tell
Yes.
me one retroperitoneal swelling you get in the right iliac fossa mass? Right iliac fossa?
Sorry, right here. Sir, swelling, sir, any swelling arises from kidneys, renal.
Yes. There has been an unascended kidney,
Yes, undescended kidney can be, yes, sir.
undescended kidney. Kidney descends or kidney ascends? Testis descends, kidney ascends.
Yes, sir. So kidney, sir, testis, yes. Testis,
No,
sir,
it can
descends,
be
the kidney
even a
ascends.
lymph node. Retroperitoneal lymph nodes.
Yes, sir.
Mass arising from the retroperitoneal lymph nodes.
Yes.
When a mass is there in the right iliac fossa mass, is it compressing on the deeper structures? You have to look for the right limb also. Is it swollen? Is there any edema? Sometimes the mass can infiltrate the iliacus muscle, producing a waddling gait. So gait also should be removed. But you
Yes,
have
sir.
not mentioned anything. First, you have not mentioned the plane of the swelling. It is
Yes, sir.
very
Plain.
important.
Yes,
Yes, please do it. Okay. Any swelling, plane is very, very important.
yes, sir.
Sir, please, sir.
Yeah,
If
Dr.
it is a
Sao,
psoas abscess,
Yes, sir.
Yes, sir.
Can
Dr.
it be a
Sao,
psoas abscess, sir is asking.
yeah, please.
Yes. Sorry, sir.
Can it be a psoas abscess?
in continuation with what Srinivasan sir said, that
Yes,
the
sir.
plane is very important, number one. Number two,
Yes.
so you have to rule out psoas abscess. What are the other differential diagnosis of lump in right iliac fossa?
Sir, sir, lump and
Can it
it
be
can be
lump
ruled out.
arising from? Can it be a lump arising from the bowel, except appendicular lump?
Sir, inflammation of sir cecum can be typhlitis, sir.
Yes. So typhlitis, amoebic typhlitis also can
Yes,
present
sir.
with a lump.
Lump in right iliac fossa, yes, sir.
Patient is having pain, fever, so you have to think of inflammatory pathology. So you have
Yes,
to think of two things, organ and pathology.
yes, sir.
So it can be a
Okay, Dr.
bowel and it
Sao,
can be inflammatory.
right.
Yes, sir.
Yes, sir, please.
Yeah. What is the amoebioma?
Yes, sir.
What is the amoebioma?
Sir, it is sir infection of amoeba, sir, chronic infection of amoeba into amoeba histolytica will present as a sir, मतलब lump in right iliac fossa into amoeba, sir.
Have you examined the renal angle and the spine?
Yes, sir.
Have you examined the renal angle and the spine?
Sir, in renal angle, yes, sir. In renal angle, sir, I sir look for tenderness or sir any percussion, sir. There is sir resonant sounds.
Have you mentioned it?
No, sir. Is
I
it
don't
normal,
remember.
sir?
Yeah.
Did you
I
examine
know.
the external genitalia?
Yes, sir.
Was the
Sir, it is
testis
within no.
present?
Yes, sir. Both testis are. No, sir. Testis are not present.
You have mentioned.
That is female.
Yeah,
Have you
female.
mentioned? No, female, sorry.
Females,
Well,
females.
did you examine the? You have not examined the external. Have you done a perirectal examination? Sorry. Sorry.
Yes, sir. I have done the distal rectal examination. Yes, sir.
You have done a digital examination. If it's a
Okay.
male, you have to examine the testis also. Undescended
Yes, sir.
testis can present as a mass.
Yes, sir. In inguinal region, yes, sir.
So, what correction you have to do is that first you have to tell us whether the lump is a retroperitoneal. How do you
Yes, sir.
differentiate between retroperitoneal and intraperitoneal lumps? Is a shift test, right?
Shifting test, yes, sir.
Right.
And patient to turn the prone. If lump is sir, more prominent, it will be intra-abdominal.
Suppose it
If
is
no change,
right. Suppose it is mesenteric lymphadenitis.
yes,
And how will you differentiate from appendicitis?
sir, different disease.
Mesenteric lymphadenitis can also present as a differential for appendicitis. much more common in children, but can happen in adults also. So how will you differentiate between the two?
Yes. Sir, a lump from mesenteric can be, sir, we can check for Tilloch sign, sir.
Tilloch sign, where do you get, pa? Where do you
Yes, sir.
get Tilloch sign?
This Tilloch sign, yeah.
Tilloch
Sir,
triad or Tilloch triad?
So in Tilloch sign, sir,
Tilloch triad, which
the
it occurs in mesenteric cyst.
cyst, yes, sir, mesenteric cyst, that it moves perpendicular to the. Yes,
But sir was asking differentiate between lymphadenitis and an acute appendicitis. Based on the pain, you can say, pa.
yes. Sir, in sir appendicitis, pain will be more severe, sir. In lymphadenitis, it will be diffuse pain, sir.
Anything
Not
else?
localized. Sir.
Anything else?
Sir, in lymphadenitis, sir, first fever will be the main complaint. Will be
No. All that is not there. Look, you mark the point of maximum tenderness.
Yes, sir.
Right? And you ask the patient to shift. If the point of maximum tenderness shifts,
yes, sir,
then it's mesenteric lymphadenitis. If it doesn't shift, then it is appendicitis.
Appendicitis. Yes, sir.
Right?
Yes.
So anyone? Or should we go to management?
What are the various signs of Suraj? What are the various signs of appendicitis? Clinical signs of appendicitis.
Yes, sir, we can, sir, roving sign, sir, in which we will press on left iliac fossa, it will occur pain in right iliac fossa. Sir, we can also swas sign, sir, in which the hyperextension of leg can pain in right iliac fossa. Sir, Dunphy sign, in which cough will occur in, sir, during coughing, sir, pain will be occur in right iliac fossa, sir. Sir, and in obturator sign will be there if pelvic appendicitis is there, sir. Sir, on internal rotation and flexion, there will be pain in right iliac fossa.
What is Romberg sign? Lumberg sign?
So sorry.
Sir asked all the signs.
Yes, sir.
Now, this patient has undergone the hysterectomy.
Yes, sir.
Okay. And the patient is presented with a nodule in that area, and the patient gets the pain in that. So can you think of any reason because of that? Presenting as a parietal mass?
Sir, parietal. Sir, it can be cold abscess maybe there in, sir, in parietal.
Cold abscess you should also consider, but gynecological cause for that, where the pain is during the menstruation. Now, this patient has undergone the hysterectomy.
Yes, sir.
But otherwise, the patient has got the pain during the menstruation.
Yes,
what can be the differential diagnosis in a female patient?
Sir, it
pain
can
during
be
menstruation, sir has given. Pain during menstruation, parietal walls were nodule. Endo? I give you a clue. Endometriosis.
Endometriosis, yes, sir. Endometriosis
That's
can
what
be.
sir
Yes,
is asking.
So you have to think about that.
Yes, okay,
now,
sir.
if you think there's a parietal swelling is there,
yes, sir.
and you are suspecting it's a cold abscess,
Yes, sir.
from where the cold abscess has come?
Sir, it can come from, sir, intercostal lymph nodes, or, sir, from, sir, port spine, sir, it can come.
So what are the findings of the port spine? What are the signs of port spine?
Sir,
Only yesterday we have discussed that, isn't?
yes, sir. Yes, sir.
Yeah. Deformity?
Yes, sir. Yes, sir. There will be a deformity, kyphosis, sir. It can be Gibbs deformity, sir.
Gibbous deformity, no? Or
Gibbous,
localized kyphosis.
localized kyphosis, yes, sir.
Localized kyphosis.
Yeah, Suraj, continuing
Yes,
with this, suppose the patient had a psoas abscess. What would
Yes,
you
sir.
find clinically to prove that How will you prove that it's false clinically?
Sir, in श्वास survey, sir, pain will be, sir, more during, sir, मतलब even the iliopsoas muscle, sir, extension,
May not,
it
not
will.
necessary, may not.
Yes, sir.
Very clinical, very clinching sign. There is what is known as fixed flexion deformity of the
Yes, sir.
right hip
Sir,
joint.
iliopsoas, right hip joint due to, sir, iliopsoas muscle involvement,
So,
spasm of iliopsoas.
so when you try to straighten the hip joint, the legs, what does the patient do?
Sir, it will, sir, flex the limb, sir.
No. You straighten the limb with your hand with force. The patient will
Pain.
arch his vertebral column. So you can put
Yes,
your hand underneath it, right?
yes, sir.
Even when the patient is sleeping, you can put. So you have to elicit this in cases of right iliac fossa lumps.
Yes, sir.
You have to mention that this is absent there. Okay.
Yes.
Yeah. Anything else, or should we go to management? Okay. Another differential for this would be an appendicular tumor.
Yes, sir.
So what are the kinds of appendicular tumor you know of?
Sir, appendix, sir, appendicular neoplasm, sir, carcinoid tumor can be, sir.
Okay, carcinoid. What is a carcinoid tumor?
Sir,
What is a carcinoid?
From
It's a
which cells do
neuroendocrine
they
tumor,
arise
isn't
from?
it?
yes, sir.
It's a neuroendocrine tumor. It's a neuroendocrine tumor. Net,
Yes, sir.
right? What other tumors do you know of the appendix? Can there be uh, any mucoid kind of tumor?
Yes, sorry, sir.
Any mucoid tumor? What is pseudomyxoma?
Pseudomyxoma peritonei, yes, sir.
So you can have appendiceal adenocarcinomas,
Adenocarcinoma, yes, sir.
mucinous adenocarcinomas,
Yes, sir, mucinous, sir, which can cause pseudomyxoma peritonei, yes, sir.
right?
Yes, sir.
So
Okay,
that
should we
you
go
have
to
mentioned
conclusion?
that. So just one point, sir.
No, please, sir. All yours.
Whether the lump is fixed or mobile,
Sir, it is, sir, fixed, sir, not mobile, sir.
it is fixed. Okay.
So, because it is fixed, there's another characteristic of carcinoid is that it has a lot of inflammation, fibrosis,
Yes, sir.
and most carcinoid tumors are fixed densely, very difficult to get rid of them,
Yes,
right?
sir.
So when they're hardly fixed, then that's this thing of carcinoids. They create a lot of desmoplastic reaction. Okay,
Yes,
how do you proceed now?
sir.
Can we think of the desmoid tumor here?
Desmoid.
The patient has undergone hysterectomy, there is a lower
Yes, sir.
abdominal scar is there.
Yes, sir.
There is a possibility of desmoid also. So all these possibilities are there. Psoas abscess, endometriosis,
Endometriosis, yes, sir.
desmoid tumor, cold abscess. Okay?
Appendicular tumors, yes, sir.
Yeah. Okay,
Okay,
go ahead.
how do you proceed now? How do you manage?
Yes, sir. Sir, sir, we will proceed with, sir, ultrasound whole abdomen. Sir, in ultrasound whole abdomen, sir, it is, sir, showing right iliac fossa region shows a heterogeneous, ill-defined, localized periappendicular mild fluid collection with internal echoes surrounding mesenteric fat showing increased echogenesis suggestive of localized shield of appendicular perforation. Sir, in routine investigation, sir,
No,
hemoglobin
just
is
go
lower,
back to
sir.
ultrasound. Hang on. Just go back to ultrasound.
Yes, sir.
You've just given the impression. What else are you looking for in ultrasound? That's the impression that right iliac fossa heterogeneity is defined.
Yes.
What else do you look for when you get ultrasound? What are you looking for?
Sir, in appendicitis ultrasound is blind tubular indicating structure like looking. Sir, yeah, yes, sir. If it is appendicitis.
Okay, you've seen that it is appendicular. Anything else which you look for? Would you look whether the two kidneys are in position or not?
Yes, sir.
Would you look if the two kidneys are in position or not?
Yes, sir.
Right, to confirm.
Yes, sir.
What do you look for in the liver?
Sorry, sir.
What will you look for in the liver? Look, when you're getting an ultrasound, just because the ultrasonologist has said this is appendicular lump, you'll accept it. Won't you look for other features which you want to rule out in your
Yes.
differential? So what
Yes,
features
sir.
will you rule out by ultrasound?
So we should rule out, sir, any abscess like the psoas abscess or sir any tubo-ovarian mass, sir. If
Right.
female is
Very
female,
good.
sir.
Very good. What else? Any liver abscess? Any secondaries
Yes,
in
sir.
the liver?
Yes, sir.
Your
Any liver.
differential could be one of those tumors
Yes, sir.
in the colon or in the appendix. So you'll have to look
Yes,
for
sir.
it. Any ascites is there? Any mesenteric lymphadenitis is there?
Yes, sir. Surrounding bowels. Sir, yes.
Right?
Yes,
You'll
sir.
have to look whether the ileocecal, the bowel is normal there or not on ultrasound.
Yes, sir. Yes.
All this has to, you just don't follow what the radiologist has told you.
Yes, sir.
Look, ultrasound is not an objective test. It's a very subjective test.
Subject.
It
Yes.
depends on the ultrasonologist. So you have to confirm what is written.
Yes, sir.
Okay. Now what do? You think
Sir.
it's an appendicular lump.
Yes, sir. So we will do
Sealed
this,
off
sir.
localized. No, hang on.
Yes.
Localized
Yes, sir.
appendicular perforation.
Yes, sir.
Okay. What are the types of appendicitis you know of?
Yes, sir.
What are the types of appendicitis?
Sir, depending on the position of appendicitis, it can be sir retrocecal appendicitis
No,
or
I'm not
pelvic
talking about the
appendicitis.
position. I'm not
Yes,
talking about. There are two types of appendicitis:
yes, sir.
obstructive and catarrhal.
Yes, sir. Sir,
You know
initially,
about it?
sir. Yes, sir.
Do you
Initially,
know
sir,
about
it
it?
will be. Yes, sir. Sir,
Yeah.
initially, there
What
will
are
be sir initially there will be obstruction, so which can cause the acute appendicitis. So after obstruction, there will be the stasis, which can cause the infection, which can form the sir. Sir, there will be sir decrease venous status. We can decrease the blood flow. We can cause the
No.
gangrene
Don't
of
give me.
sir. Yes,
Dr. Sahu, I'm
yes, sir.
not asking Suraj. Suraj, are you
Yes, sir.
Suraj?
Yes, sir.
I'm not asking you the pathogenesis. I'm asking
Yes,
the two types. What is catarrhal type and what is obstructive type?
yes, sir. Sir, in obstructive, sir, the appendicitis occur due to any obstruction to the sir, lumen of sir appendix.
Right. Very good. And what is catarrhal type?
Sir, in
From
catarrhal,
which year?
sir,
Suraj, which year are you in? Second year, third year?
sir, second year, sir.
Second year. Appendicitis कर चुके होगे, must have operated.
Yes, sir, I have assisted. Sir.
Assist care, not done it independently. Okay. So have you
So,
read Bailey about? Have you gone and read Bailey about appendicitis? No, you haven't.
yes,
I can tell you haven't.
yes,
Because had you read about it, you would have told me what is catarrhal type,
yes, sir.
right? तो
Yes.
बेटा सेकेंड डे में पहुंच गया बिली लव तो खोलो रोज अपेंडिसाइटिस देखते हो रोज करवाते हो करते हो एंड यू डोंट नो
Yes, sir.
you get me
Yes, sir.
appendicitis so you have to know everything about appendicitis more than what even McBurney knew about appendicitis.
Yes, sir.
You get me? Yeah.
Yes,
So catarrhal type is when there is inflammation without
yes,
any
sir.
obstruction.
Yes, sir.
Right. So what is an absolute condition where you have to do an appendicectomy? There's no perforation, there's no
Yes,
pain. You get an X-ray done, and your boss says no. Get an appendicectomy done. What? When?
sir.
When you find a
If the
fecalith.
Yes,
It's in
fecal
the
absorption.
lumen. Yes,
Lumen,
that's
yes,
an absolute condition
yes.
when you have to do this. Okay. So you've done ultrasound. Now what else?
Sir, if hemodynamic instability, sir, any signs we can go for.
No, what else will you do now? You've got
Yes,
this
sir.
patient. What will you do with this patient? You've got ultrasound done. What else?
Yes, sir. Sir, we will send the sir routine investigation. Sir, in routine investigation, sir, TLC is sir higher side. Sir, hemoglobins are lower side. Rest are within normal limits, sir. Sir, after that we have the C. Yes. So after that we have the CCD whole abdomen, so in which the asymmetrical
Why
heterogeneous
did you do a
enhancing wall.
CT? Why did you
Yes,
do
sir.
a CT abdomen?
Yes,
Why was
sir.
a CT abdomen done? The ultrasound is sufficient. It says, okay, fine, the patient is okay, hemodynamically stable,
Yes, sir.
afebrile. Is she passing flatus?
Yes, sir.
Passing
C is
motion?
passing. Yes, sir.
Passing flatus in motion.
Sir, yes,
So
sir.
why do you want? So why do you want to? Abdomen is soft. You said it's soft. So why do you want to get a CT done?
Sir,
To confirm your ultrasound.
to confirm the diagnosis.
Why? You think your ultrasound has not confirmed your diagnosis, or you clinically have not confirmed your diagnosis? What do you want to confirm? Appendicitis or something? You want to rule out something
Sir,
else?
yes, sir.
What do you want to rule out?
Sir, we can rule out the surroundings, sir. Any inflammation, sir, any mesenteric lymphadenopathy, or sir,
You
any
think an
sir
ultrasound cannot
pathology.
pick that up? You think an ultrasound cannot pick that up?
Sir, it can be.
Are, are you going to operate on this patient?
Sir, no, sir.
Then why do you want a CT scan then? Look, just
Yes,
you
sir.
don't have to get my opinion.
Yes, sir.
CT scan is not required here. You just feel a lump, nothing else.
Yes.
Ultrasound is clear. No other pathology seen. Patient is passing motion in flatus.
Yes.
Why should you go in for a CT scan?
Yes, sir.
Okay. So
Yes.
now what do you do? Okay, okay, you've got a CT. It confirms
Yes.
what
The
your
diagnosis.
ultrasound told you.
Yes.
Okay, it says, no,
Sir.
just show me the CT's report.
Yes, sir.
It says a phlegmon. What's a phlegmon?
Sir, phlegmoid is the appendicular epidermis formed by the surrounding inflamed appendix with greater momentum and surrounding sir bowels. Sir,
So what's the
terminal
difference between
ileums.
an appendicular lump and a
Yes, sir.
phlegmon?
Yes, sir.
What's
Yes,
the
sir.
difference between an appendicular lump and a phlegmon?
Sir, phlegmon is a sir, मतलब inflammatory sir surrounding sir bowels and omentums are attached with sir appendix.
So what is then what is appendicular is the same thing.
Yes, sir.
The basic difference between an appendicular lump and a phlegmon is that there is collection of pus.
Yes, sir.
If pus is there, it's phlegmon.
Yes,
You
sir.
get me? So this is an appendicular abscess,
Yes, sir.
right?
Yes.
Does your thing say any collection of pus?
Yes, sir.
Does your CT note there is any collection of pus?
No, sir.
Then why have they called it phlegmon?
Sir, there is no
That's what says it.
any
So this is
CT
phlegmon.
ultrasound.
No, there's in CT they don't say there is any. Okay, anyway, something wrong somewhere. Phlegmon means there has to be pus. Now suppose
Pus.
it's an appendicular abscess.
Yes, sir.
What is the difference in management between appendicular lump and an appendicular abscess?
Sir, in appendicular abscess, sir, we have to drain the pus, sir. Sir, with
You have
after
to
draining the
intervene.
pus, we will do the. Yes, sir.
You have to intervene.
Yes, sir. We
Right?
have to intervene, sir. Yes, sir.
Right. So what kind of drainage do you do in an appendicular abscess?
Sir, percutaneous drainage can be done, sir, and usually guided, sir.
Extraperitoneal. Professor Dalvi is raising his hand. Sir, please.
Yes, sir.
Professor Dalvi, sir.
So, is there any
Suraj,
role of laparoscopy?
can you hear
Yes,
me?
sir. Yes,
Yes,
sir.
sir, please go on, sir.
Yeah. See, phlegmon is pus without capsule. and
Yes.
abscess is with capsule. Pus
Yes.
without capsule is difficult to drain unless you operate on this patient, but ultrasound guided, etc. Abscesses are the ones which has a capsule, so it can be easily drained. That's the clue for you for further questions.
Yes.
Right. So that is exactly. Phlegmons are usually collection of pus within the surrounding structures, forming a kind between the surrounding structures. Abscess, appendicular abscess has to have a capsule. So usually we have
Yes.
a appendicular phlegmon. Having an abscess is very rare, right? So it's a appendicular
Yes.
phlegmon. Now what do you do?
And
So
one more point, sir. In CT, it is written that there is a thinning of wall of the tip of the appendix with adjacent extraluminal air foci.
Okay, I've not seen. Yeah. So what does that mean
So
now?
that,
yes. So it is sealed off, sir, perforation maybe, sir.
Okay. So when
that's
do you
why they
think?
might have written phlegmon.
Okay, Dr. Suraj,
Yes, sir.
when does the tip of the appendix get perforated, and when does the appendix get perforated at any place other than the tip?
Yes. Any case other than, sir?
When does the tip of the appendix get perforated? Give me the answer first for that, then I'll ask you the next one.
Sir,
In what
sir,
type of appendicitis will you expect the tip to get perforated? I told you there are two types, obstructive and
yes, sir.
catarrhal.
Yes, sir.
So which of these
Sir,
two?
in obstructive, sir, tip will be the most common site of.
No. In obstructive, it perforates at the site of obstruction.
Yes, sir. In catarrhal,
Tip
sir.
gets
Yes.
in catarrhal because of there is thrombus or thrombophlebitis, thrombus of the uh, there's obstruction of the appendicular artery
Yes,
due
sir.
to inflammation. So the tip loses its blood supply and gets perforated from there. Okay. Now Professor Dalvi asked you, gave you that it is phlegmon without a capsule, right? It's pus without a capsule. So what do you do now?
Sir, if the patients are hemodynamic stable, we can manage the patient conservatively, sir, by
Okay.
osmotic saline regimen. Yes, sir. If it
Now,
localized peritoneum, yes, sir.
why should you put the patient nil or what is Oshner?
Sir, in osmosis, sir, we will admit the patient, put the patient nil per oral, and give the, sir,
No,
IV fluids
Oshner
with,
for acute or for chronic?
sir. Yes,
You
sir.
think
It's
this
for
patient
acute,
is an
sir.
acute appendicitis? You think
Acute,
this
acute
patient is acute?
appendix. Yes, sir.
You think this patient is acute appendicitis?
Yes, sir. The patient acute appendix.
You think it's acute? यार फ्लेगमॉन
Yes, sir.
फुगमन बन गया इसको ब्लम बन गया एक्यूट हो रहा है एक्यूट तो होता है विद इन 24-40 जब एवरीथिंग इज ओके जस्ट
Yes, sir.
प्लेन appendix. So
Yes,
osteal
sir.
sharing is for acute abdomen,
Yes, sir.
not for this
Yes,
case.
sir.
So osteal sharing, keep the patient nil, or you keep this patient nil orally.
Yes, sir.
You want to keep this patient nil orally. She's been eating for last 8 days here. She's been eating for 8
Yes.
days, huh? So
Yes, sir.
what will you do by keeping a nil oral now?
Yes, sir. If patient is passing flight, sir, we will not do the nipple.
So what will you do now? What will you do now?
So we will manage with, sir, IV antibiotics and IV analgesics.
Right, very good. They give fluids, they give antibiotics, right? Her count
Yes,
was how
sir.
much? 14,000. Her count was TLC was how much? 14,000.
14,000. Yes, sir. 14,300.
So you give this, you see whether the count has come down, her tachycardia.
Yes, sir.
How much was the
Yes,
pulse?
sir.
How much was the pulse? Was it
Yes, sir.
over 100, below 100?
So it is below 100, sir. 76, sir.
Yeah, so come on. Then there's hardly any pulse also there then. If there is pulse, the pulse cannot be 76.
Yes, sir.
So she's resolving.
Yes, sir. She is in resolving phase. Yes, sir.
Resolving. So you do nothing, you just put her on antibiotics. And now suppose
Yes, sir.
this was an appendicular abscess.
Yes, sir.
Now what do you do?
Sir, we will, sir, first, sir, drain the abscess and we will give, sir, IV
How
antibiotics
will you
and
drain the
IV
abscess?
analgesics.
What is so particular about this? Some word written there in
Yes, sir.
Bailey for appendicular abscess. What
So
is
we
that
can
word there?
sir percutaneous passage.
No, it's not in percutaneous. Percutaneous is very, you will perforate
Extra peritoneal.
the, yes, extra peritoneal.
Sir, peritoneal. Yes.
Yes, extra peritoneal, right?
Yes, sir.
So anyone?
Let's see the appendix. What is the commonest position of the appendix that is? So,
Yes, sir.
what's
Sir,
the
retrocecal,
commonest
sir.
position of the appendix? It is
Retrocecal, sir.
60% is a retrocecal
Cecal.
paracecal. In case
Yes,
only
sir.
you can go for X-ray. If it is a pelvic, you have to do a AC
Yes.
set. You go for either laparoscopically or through rectum. You can drain the appendix. And one more
Yes.
point to add, your case only 8 days old, right? You see, so
Yes. Yes.
for 8 days. So this case, the patient is an evolving phase of an abscess. From like one, you go to the abscess formation. That's why you have to answer, right? And one more thing, there are points to say. See, you have to, as a PG, you have to say what is given the textbooks. Say, we are all
Yes,
talking
sir.
about our experience. But
Yes,
you
sir.
have to tell what are given in the textbooks, what is the investigation further, and what will see in ultrasound, what is the finding to say it's acute appendicitis. There are some signs, right? You have to show
Yes.
those signs. And regarding the particular mass, see the interval appendectomy is a standard protocol. But that
Yes.
we are at the age of minimally access surgery. There you have to say, yes, sir, I will do. There's one entity called hydrodissection or an Archimedes principle. See, when you are a well-trained man, you can do a appendectomy in case of it is a early stage where these are a flimsy adhesion. If you do hydrodissection, you can separate the, as you said, separate the omentum and ileum, and you can easily see the appendix. Right? That is the way you have to answer. Suppose the count is more than 25,000. What do you think of?
It will be not in the it will be in sepsis phase, sir. The abscess, sir. It
No,
will form in abscess.
there are certain, based on the count, it is 14 to 15,000, 6 acute inflammatory. If it is
Yes, sir.
between 15,000 to 20,000, think of there's a perforation. So more than
Perforation.
20,000, think of it's a gangrenous appendix. There's no role. You go laparoscopically, give a wash blood and come out. That's the
Yes.
way you got to answer. Suppose they are asking, there is a mass, how will you do that? There are chances I may injure the either cecum or 10 million. So there we go
So it
for
can
after
fecal
putting my
injuries.
laparoscopy, the laparoscopy is the gold standard. I will judge my what do you say, my ability. You are in problem, call your seniors. That's your answer. Right.
Yes.
If it is a turned out to be a what are other
Okay,
complications of the appendicitis?
Yes, sir. Yes, sir.
If it is an intra-loop abscess formation, how will you do? So there you have
So
to go only as a laparotomy, laparoscopy, you have to enter thorough walking.
yes, sir.
That way you
Yes,
have to
sir.
answer. Very good.
Yes, sir. Yes.
Okay, Suraj, sir asked you which
Yes.
is the most common position of appendix, and you said
Sir,
retrocecal.
retrocecal. Yes.
Right. So this is also known as silent appendix.
Yes, sir.
Right. Why is it called silent appendix?
Sir, due to the position, sir, retrocecal, sir, the pain and tenderness will be, sir, localized, sir. It is not easily, sir, fine. Matlab,
Very good.
signs will be
So
not so
what?
easily.
Yeah, very good. So what test do you do to diagnose that this is retrocecal?
Sir, we can do the SWAS test, sir.
What was
So
it?
in which, sir, hyperextension of hip can cause the pain, sir.
Why?
Or
Why
sir,
does that happen?
yes, sir.
Why does that happen? Why does hyperextension of the hip have to be done? Has to be done to elicit
Sir, in
pain?
yes, sir, in hyperextension, sir, it will, sir, there's a pain. The load, sir, the pressure will be on retrocecal side, so it will cause the pain, sir.
It will cause contraction of the psoas.
Yes, sir. Cause SWAS to it. Yes, sir.
And what about pelvic? What test do you do for
Sir,
that?
in obturator test, sir, it will the internal rotation and flexion of hip, it will cause the.
Right. Very good. Okay. So you've done this, and the patient is is relieved. There's no lump.
Yes,
Everything is done. Now,
yes,
what do you do when you're discharging a patient? Will you ask her
sir.
for a interval appendectomy, or will you not do anything? Or and when if you do interval appendectomy, when do you do that?
Sir, there are, sir, 20% chances of sir, recurrent appendicitis, sir. We can go for sir interval appendicectomy.
No, you can go for hemicolectomy also. Tell me what will you do and why?
Sir, we will with patient come to do follow up, sir. We will do the interval appendicectomy. Plan for
Okay.
sir.
Nowadays, people say there's no role of interval appendicectomy. If
Yes,
she
sir.
has an attack, she
Yes,
should be
sir.
asked to come and do the surgery there and then,
Yes, sir.
right?
Within 70. Yes, sir.
Or if the patient is living in such a remote area where
Yes, sir.
medical facility is not available, or she's going to the moon, or she's going to Antarctica, then appendicectomy has to
Yes, sir.
be. Okay?
Matlab, if she can follow up, sir, we can matlab, we can
Yeah.
plan, not plan for appendix.
Sir, anyone?
What are the uses of the appendix in human being?
Yes, sir.
Yeah.
What is?
Good.
What are the uses?
Sorry, sir.
New concept about the
Okay.
appendix.
What are the sir?
New
Uses.
concept
कहाँ
about
इस्तेमाल
appendix.
कर सकते हो appendix को?
Yes, sir.
What was it
Appendix
used
has
for?
sir. Sir, appendix has the sir gut associated lymphoid tissue, sir. It will have a role in sir immunity, sir.
Then
What else? Can you use it for something? Is the appendix used for any procedures? Dr. Suraj, are you there?
Yes, sir. Yes, sir.
Yeah.
Yes.
Any
What are
urology
the
procedure?
other uses of appendix?
Sorry, sir.
Mitranov का नाम सुना? Mitranov.
Yes, sir.
Mitranov. नहीं. Okay. It can be used to replace the ureter. It can be used as a continent conduit, ileal pouch conduit for both fecal matter for urine. Right? Go and read about it. There's a lot of things about it. Just go and read.
Yes, sir.
So, answer, sir, Dr. Karnakar, sir.
What is pile phlebitis?
Yes, sir.
What is pile phlebitis? Can a patient with appendicitis can have the pile phlebitis?
Sir.
You understand what is pile phlebitis?
No, sir.
What is portal vein thrombosis?
Sir, yes, sir. In portal vein thrombosis, sir, there will be sir pulmonary, sir.
So can appendicitis lead to portal vein thrombosis? Yes, it can cause,
Sir,
no?
it can
Inflammatory
cause.
causes for the portal hypertension, like somebody
Yes,
has
sir.
got the pancreatitis or appendicitis or diverticulitis. All these can
Yes.
lead to the portal
Portal
vein
vein.
thrombosis, and that is the portal pyemia or pile phlebitis. They are almost the similar words which are there. Okay.
I think
We can
I
go
think
to the next
Dr.
case here.
Kanabul, sir.
Yes, sir.
No. Okay, Suraj,
Yes, sir.
you have got any queries? Any questions? Any doubts? Anything you want to
Suraj,
ask?
Yes, sir.
Suraj, if your operated
Yes.
specimens, the pathology says there is a carcinoid features are seen in the histology. How do you manage?
Sir, there is in pathology, sir.
Carcinoid
Carcinoid.
features.
Suppose you're operating and there's a lump at the base of the appendix,
Yes, sir.
less than 2 centimeters. What do you do? Okay, you got
Sir,
a lump at the tip of the appendix. You got a lump in the middle of the appendix. You got a lump at
Yes,
the
sir.
base of appendix. Less
Yes,
than
sir.
2 centimeters, more than 2 centimeters. What do you do?
Sir, in less than 20 minutes, sir, we will do only appendicectomy, sir.
Where? The lump is where?
Sir, in the tip or sir, body.
Right, very good. So you do an appendicectomy, fine.
Yes, sir.
Suppose it's at the base.
Yes, sir.
Or no, let's go. Suppose it's at the tip or the body more than 2 centimeters. What do you do? What are you fearing?
Yes, sir.
What are you fearing?
Sorry, sir.
What do you think? Why is this question being asked?
So, what to do if the lump present in the lower side base of the appendix?
Yeah. Carcinoid hoga na? Commonest
Yes, sir.
tumor.
Yes, sir.
So what do you do? What do you do then? If it's at the base,
Sir,
you'll
yes,
have to
sir.
do a hemicolectomy.
Hemicolectomy, yes, sir. With him.
And how do you test for it?
Yes, sir.
How will you follow up that patient if the patient has carcinoid?
Sir, we got the immunochemistry sets as synaptocin and sir, chromogranin. We can be shown in
Get your
carcinoid.
chromogranin A. You get
Yes, sir. Chromogranin
serum
and
chromogranin
synaptophysin.
A.
Yes, sir.
And what is the scan we do for it?
Sir, immunohistochemistry, sir.
There's a particular scan for it. DOTA T PET CT. Okay.
PET CT. DOTA PET CT.
Yes. Okay. Anyone,
what will you see in the,
Yes, sir.
in case of carcinoid, what will you see in the urine?
Yes, sir.
In case of carcinoid, what will you see in the urine?
Sir, there is secretion of 5-HIA, sir. It will be detected.
Super of 500, right? Simple test, but study in the right?
Yes. Yes, sir.
I think we are done.
Yes, sir.
Call doctor.
Yes, sir. Yes, sir. We can proceed with the next case
Yeah.
with
The next
Kanagwal, sir.
person?
Yes, sir.
Who's the next person in line for presentation? Are you there? I'll just call Dr. Kanagwal too.
Hello, Kanagwal?
Call the next person.
Good evening, sir.
So the next presenter is from Chengalpat Medical College. Is she ready?
Sir, good evening, sir.
Yes, ma'am.
Are you ready?
Good luck.
Yes, sir. Thank you, sir. Screenshot.
Click on that PVD final you put. Go to the slideshow. Top. Yeah. Good. It's visible. Carry on.
So, good evening, sir. I'm Dr. Malini from Chengalpattu Medical College under the guidance of Dr. V.T. RSS, sir. I'm starting with the case of peripheral arterial disease. A 60-year-old male from Kanjipuram, farmer by occupation, came with chief complaints of blackish discoloration of left great toe and little toe for past 1 month. Patient was apparently normal before 3 months. Then he had cramping type of pain over the left leg, which was intermittent in nature, gets aggravated on walking and relieved on taking rest. Initially, the patient had pain over the left leg while walking at a distance of 500 meters and relieved temporarily by taking rest. Now the patient has lost pain even after walking at a distance of 100 meters. History of rest pain for past 3 weeks, which is continuous and aching in nature. Pain gets worsened at night, aggravates on elevation of the leg, relieved by hanging the leg or by holding the foot. History of blackish discoloration of the left great toe and little toe for 1 month. Initially, it started at the tip of the toes and it progressed up to the midfoot and not associated with any discharge. No history of loss of sensation, no history of trauma, no history of fever, no history of leg swelling, no history of any ulcer or discharge. No history of discoloration of the fingers on exposure to the cold environment. No history of postprandial abdominal pain. No history of syncope or blackouts. No history of blurring of vision. No history of chest pain or palpitation. No history of erectile dysfunction. Comorbid history. Patients a known case of type 2 diabetes mellitus for the past 20 years on OHA drugs. No history of hypertension, epilepsy, CAD, CVA or COPD. Past history, no history of any major medical or surgical illness. Personal history, patient takes mixed diet, bowel and bladder habits are normal. Patient is a known smoker for the past 20 years. He smokes 10 cigarettes per day and smoking index is 200 and the pack year index is 10. He is not an alcoholic. Family history, no history of similar illness in the family members. Summary, a 60-year-old male who is a chronic smoker and a known diabetic with complaints of intermittent claudication for 3 months and having rest pain for 1 week with a blackish discoloration of the left great toe and the little toe for the past 1 month would probably a case of left lower limb peripheral arterial occlusive disease.
You go to the first slide, starting so when they can ask questions.
Yes, sir. Yes, sir.
So it's only in the great toe and little toe, isn't it?
Yes, sir.
Not above that one. Go to the next slide.
Nothing in between. Other toes are all normal.
Yes, sir.
Yeah.
Okay. Very peculiar. Next
You have the
slide, please.
picture?
Yes, sir.
You
For
have
the
the
clinical.
picture?
Yes, sir. Yes, sir. Yes, sir. Can I show that now, sir?
You should
Yeah,
put
let's
the
have a look.
picture in the first slide or slide. When you start pressing in the heel, you should press it.
Okay.
So it is extending proximally also. The blackish discoloration.
Yes,
It's
extending
the whole of the
proximally
forefoot almost.
Yeah,
Yes,
it's
sir.
almost.
Except for the second toe, all the other toes are affected. Anyway, yeah, let's go to your history now.
So his claudication
No,
distance is come down.
Next slide, please.
Yes, sir.
Next slide, please.
Next slide. His claudication distance is coming down.
Yes, sir.
So that means the disease is progressing.
Yes, sir.
Okay, next slide.
This from 500 meter to 100 meter happened over a period of how many days?
Sir, it's for 2 weeks.
Was it?
Within a 2 weeks period, sir.
So it is progressing rapidly.
Okay, next slide. Okay, next. Okay, fine. Okay,
You have written,
so
sir, one
Yes, sir.
question. She has
Yes, sir.
written history of loss of sensation. Is
No,
it
sir.
no history or history of loss of sensation?
History, sir.
Yes,
Presence of loss
No,
of
no.
sensation.
The first line you have written
yes, sir.
history
Yes,
of
sir.
loss of
Yes, sir.
sensation.
Yes, sir. It is history of loss of sensation plus, sir.
where
So
where
what do you mean
sensation
by
where?
that?
Over the foot, sir.
Over
Whole
the
foot.
affected area or anything beyond it?
Sir?
Is the loss of sensation restricted at the affected area or beyond it also? Proximal to it also?
Only over the left foot, sir.
Okay. The sensation. Okay, we'll discuss that later on. Yeah.
Yes, sir.
Next slide, please.
Okay, sir.
Okay.
No,
Okay.
you
Next.
have elicited all the findings, ma'am. But I personally feel that it's of the lower limb. Okay, so
Yes, sir.
it starts from the foot. So you should ask for any history of calf muscle pain,
Okay,
history
sir.
of thigh muscle pain, then
Okay,
go
sir.
up history of gluteal claudication,
Yes, sir.
erectile dysfunction,
Yes, sir.
abdominal pain,
Okay, sir.
any loin pain.
Okay, sir.
Then go in an ascending order. You put the symptoms means it will be good.
Okay,
So
sir.
is
Yes,
it
sir.
confined to the foot? You're jumping from the foot to the upper limb. You're
Yes, sir.
jumping
Yes.
from the upper limb coming to the abdomen. So you start from the lower limb, ascend and slowly. The symptoms
Okay,
should
sir.
be in a chronological order.
Okay, sir.
Then you go to the upper limb nothing. Then go to the head and neck. Then
Okay,
come
sir.
to the made a history of chest pain.
Yes, sir.
You have written yes. So it should come in an order.
Yes, sir.
That's what I say. Okay.
Yes, sir. Yes, sir. Yes, sir. Sure, sir.
Please change it next time.
And since you have written all the systems, when patient is diabetic since 20 years, you should have thought of CRF also. Symptoms
Yes,
of
sir.
CRF. Okay.
Why
Then
did
please
you ask
carry on.
about erectile dysfunction?
Sir.
Sir?
Why did you ask about erectile dysfunction?
Sir, it is to rule out any iliac obstruction, sir.
What is that
What is
called
that
as?
syndrome called?
The syndrome is named as Leret syndrome, sir.
Eric syndrome. Good.
It has got three things. One is
Yes, sir.
gluteal
Absent
claudication,
of femoral
femoral
pulse,
pulse, and erectile dysfunction.
gluteal claudication and thigh claudication, sir. And
Erectile
erectile
dysfunction.
dysfunction.
Yes, sir. Please. Next
Yeah,
slide.
go on.
Go to the examination
Only,
now.
Yes, sir.
only. But what are the causes for pain in the lower limb? Apart from this vascular disorder, what are the other causes of pain? You have to ask for that.
Yes, sir. It could be due to any neurogenic cause or any vascular cause, sir.
You said all you said are about the vascular disease. What
Yes, sir.
about there's the limb gas, artery, vein, and
Yes, sir.
the musculoskeletal system. And also you may think of higher level. You got a disc. So these are the area you have to ask. So
Okay, sir.
you have to go negatively also. That is also very important.
Okay,
Right?
sir.
In case
Okay,
of
sir.
a disc prolapse, how will be the pain? In
Okay,
case of
sir.
a cardiac, so how is the pain?
Okay,
Then
sir.
what is the distance? When
Yes,
then
sir.
on the old age, there is a O is more common. So these are the three category you have to say in the exam,
Okay.
right?
Okay,
ahead.
sir. Yes, sir.
Okay. Biohistory, what do you think you're dealing with?
Sir?
Biohistory.
Yes, sir.
Let's go to your last slide on history.
Yes, sir.
Yeah, summary. Now, what is your conclusion by history?
So with the age of the patient and the smoking history with an associated diabetes, and also patient has got intermittent claudication and associated with the rest pain, with the discoloration of the foot, I would categorize this to be a case of left lower limb peripheral arterial disease, occlusive disease, most commonly due to atherosclerotic changes. Sir.
Okay. I say that because he's smoking,
Okay,
I say
sir.
that this is Burgess disease.
Sir,
Prove me.
it is contradictory to the Burgess disease because the age of the patient is already 60 years, sir, and is also having a known comorbid. Comorbid is associated with
Which
with this
criteria?
patient.
Which criteria it is?
Shannon's criteria, sir.
What is Shannon's
Come on.
criteria?
Shannon's criteria: the age of the patient should be less than 45 years.
Yes.
He should be a smoker. It should not be associated with any other comorbids other than the smoking history. Infrapopliteal lesions are involved, and superficial thrombophlebitis, sir.
Okay.
Okay. Should we go to the
Yes, sir.
examination? Yeah, examination.
Yes, sir. Yes, sir. General examination. Patient is moderately built and nourished, conscious, oriented, and afebrile. Hydration is spare. No pallor, no cyanosis, clubbing, edema, or lymphadenopathy or icterus. Attitude of the limb, sitting with knee flexed at the edge of the bed. Gait is limping. Spine is normal. Nicotine staining of the gums and the fingers are seen. Weight 58 kg, height 168 centimeter, BMI is 20.6 kg per meter square. Vitals, right radial pulse 80 per minute, regular in rhythm, normal in volume and character, no radial or radiofemoral delay. BP 170 mm Hg in the right arm in sitting position and 110 mm Hg in the left arm in sitting position. Saturation is 97% under room air. This is a clinical image of the patient, sir. Local examination of the left lower limb. Attitude of the limb. On inspection, attitude of the limb, sitting with knee flexed at the edge of the bed. Gangrene of the left great toe and little toe is present, extending up to the first and fifth metatarsophalangeal joint in both dorsal and the plantar aspect, and up to midfoot on the dorsal aspect. Line of demarcation at the level of metatarsophalangeal joint, circumferential, and other three toes are comparably pale. Limb proximal to the gangrenous area is comparatively pale up to the lower third of the leg. Skin loss of luster and dry, loss of hair over the left leg on the foot, loss of subcutaneous fat, brittle nails are present in all the toes, no discoloration along the veins, Burgess angle is 20°, muscle wasting is present on the calf muscle, movement restricted over the toes. Palpation, on comparing both the lower limbs, affected limb is comparatively cold up to the midfoot. Gangrene of the left great toe and the little toe, which is dry and shriveled with absent sensation. Tenderness present over the midfoot up to lower one third of the leg. No crepitus, no pitting edema present in the other three toes. Tests for circulatory insufficiency. Capillary refilling is delayed. Venous filling is delayed. Fuchs test is negative. Movements of the joints restricted in the great toe and the little toe. Examination of the lymph nodes, there are no regional lymphadenopathy. Bulk of the muscle, obvious wasting is present. On mid thigh, on the right side is 45 centimeter, on the left it is 43 centimeter. Mid calf it is 30 centimeter, on the left side it is 25 centimeter. On examination of peripheral arterial pulsation, on the right and the left comparatively, on the left side it is absent from the popliteal onwards. On the right side, all the pulses are palpable. Examination of the right lower limb, it appears normal, no black patches or gangrenous toes or loss of function or sensation or pulsation. Examination of the upper limb appears normal, Allen's test negative, Adden test negative, and there are no neurological deficits. Auscultation, no bruit is heard along the lower limb or the upper limb vessels. Systemic examination, CVS S1, S2 is heard, no murmur. Respiratory, normal vesicular breath sounds heard. For abdomen, soft, non-tender, no organomegaly. CNS, no focal neurological deficit. A summary, a 60-year-old male, chronic smoker, known diabetes with complaints of intermittent claudication for 3 months, associated with rest pain for 1 week, with a blackish discoloration of left great toe and little toe for past 1 month. On examination, there is dry gangrene of the left first and fifth toe with signs of ischemia with absent pulse distal to the femoral artery pulsation. So in the case of peripheral arterial occlusive disease affecting left lower limb with the chronic limb-threatening ischemia with the femoropopliteal occlusion, probably due to atherosclerosis under Rutherford category 5.
Okay. Dr. Mali, let's go to your examination.
Yes, yes, sir.
Regional examination. Right. The first thing you have to do is that you have to compare the two limbs together.
Sir?
Right? That comes before. The first thing you do in a peripheral vascular disease is they have to compare the two lower limbs.
Okay, sir.
And you have to compare the two lower limbs
Okay,
first
sir.
before proceeding.
Okay, sir. Okay, sir.
That's enough. Okay.
Okay, sir. Okay, sir.
Okay. You've not told me about any movement of have you tested the range of movement of the joints?
So restriction of movements noted over the toes, sir.
No, you have to examine all because you said the patient sits with holding his foot in his hands.
Oh, yes, sir. Yes,
Like
sir.
that, huh? Why do you think he does that?
He does that because to relieve the rest pain, sir, that most commonly occurs over the calf
Why,
region.
how does that relieve breast pain?
So, sorry, sir.
How does holding it in his hands relieve pain?
First is by psychologically, sir, it gives relief. Second, by massage during ischemia, the calf muscle goes into contraction, sir, and by massage it gets relieved. And there is alternative pain pathway gets altered by doing it, sir.
You've given me all the answers except the correct one.
Close to the
Dr.
heart.
Malini, holding
Yes, sir.
it keeps it warm.
Yes,
Holding
keeps
it
it warm. Yes, sir.
keeps it
Yes,
warm.
keeps it warmer. Yes, sir.
All the psychological and secondary pain pathway, please. Okay, right.
Yes, sir.
So you have to test the range of movement. When the patient is sitting like that for a long time, they usually have contracture at the knee joint.
Okay, sir.
You've not tested the gait of this patient, right?
Yes, sir.
You've not tested all his sensations, his sense of vibration, his sense
Yes, sir.
of fine touch and sharp touch. You've not tested for sense of position of the joint,
Yes, sir.
right? All this is missing. Look,
Okay, sir.
you have
ABPA also, sir. Ankle brachial pressure index.
you have to rule out neurologic and venous before coming to your arterial disease.
Yes, sir.
In all peripheral disease, vascular disease, if it's venous, you have to rule out neurological and arterial. If it's arterial, you have to rule out venous and neurologic, right?
Yes, sir.
So you must know the difference between the three of them.
Okay, sir.
Can you rattle it off to me? What are the difference between the three?
Between arterial, venous, and neurogenic, sir.
Yeah.
Yes, sir. Yes, sir. Arterial pain will have cramping type of pain, and venous it will be a bursting type of pain, and then neurogenic it will be
Cramping, bursting is doesn't mean anything much. Give me
yes, sir.
hard facts.
Okay, sir. Or in arterial, the pain does not pain occurs only after walking few steps, whereas in
Intermittent claudication. You
yes,
just say the word
yes, sir.
intermittent
Intermittent
claudication
claudication. Yes, sir.
and or rest pain. This is arterial. Anything
Yes,
else? Next.
intermittent claudication will be present in arterial, whereas in neurogenic and vascular, the peripheral pulse will be present. And then in neurogenic, there will be change. I mean, pain gets relieved in the postural change, sir.
Pain on rest.
Yeah.
The pain will get relieved on rest. When if he's got
Pain gets
intermittent
relieved on rest.
claudication, the pain stops when he stops walking after some time. What
Yes,
about
sir.
venous pain? What
Sorry,
is
sir.
venous claudication? What is venous claudication?
Pain does not get the patient does not get does not get relieved, sir.
Of course, it gets relieved. Look, venous claudication is not as fixed as arterial claudication.
Yes, sir.
Arterial claudication, he knows that from here, if I reach the gate, I'll get pain.
Sir.
Venous claudication does not have a definite distance.
Okay, sir.
Arterial claudication is relieved by hanging his foot or resting.
Yes, sir.
Venous claudication, he has to raise his legs,
Yes.
his limb. Right? It takes
Yes,
a
sir.
longer time to get relieved. You get me?
Yes, sir. I
Then
got
of
it,
course
sir.
the pulses, all that. So go through them. So anyone.
In neurological claudication, most of the times patient has a pain in the first step.
Yes, sir.
And can you tell what is venous claudication? What is the basic cause?
Venous claudication basic cause is made due to edema, sir. Or the obstruction
Long-standing
of
venous,
obstructions.
long-standing varicose veins, you will
Yes,
have the
sir.
dilated and stretched veins. So that stretching of the walls is there, and pooling of the deoxygenated blood,
Okay, sir.
which deprives the tissues of the oxygenation. So there will be hypoxia. So there will be
Okay,
a
sir.
pain at the end of the day.
Okay, sir.
So when the patient raises the foot above the head, it gets emptied, so the pain disappears.
Yes, sir.
Okay.
Okay, sir.
Sir, is it that you wanted?
Sir, even they say that in a post-thrombotic leg, patient is having deep vein
Oh, sir.
thrombosis. When
In
patient
deep vein
starts
thrombosis.
walking, the venous return also are hampered, so patient gets pain.
Okay.
Malini, if
Have
you
you
have
done
done the ABPI in this patient,
Yeah, I
what will be
asked,
the
sir.
what will be the ABPI on the left side?
It will be less than 0.4, sir.
Mhm. Can you tell what are the various limits there for that?
Yes, a
What is the
normal
normal?
value. Yes, a normal is 0.9 to 1.4, sir. If it is less than 0.9, it indicates peripheral arterial disease. And if it is less than 0.4, it indicates critical lymph-threatening ischemia, sir. And if it is more than 1.4, it indicates a false value, probably seen in patients with diabetes, sir.
It is because of
Calcified
what?
vessel cells.
Because of calcified vessels.
Calcification of the vessel walls.
Okay. So if there is a ABPI you are getting, then what next test you will do?
Toe brachial
If it
and
is
toe brachial pressure, sir.
toe brachial pressure. Good. What is the normal toe brachial pressure?
More than 60 Hg is normal, sir. If it is less than 30 Hg, it indicates ischemia, sir.
Good. Okay. So what is your final diagnosis?
Malini,
Yes,
what's
sir.
the use of cutaneous oximetry estimation?
Cutaneous oximetry in case if we are not able to get the pulse by toe brachial pressure also, sir, we can use transcutaneous pulse oximetry, sir.
What's the use?
But it can be done bedside. It can be done by even by a normal person, sir.
Denotes the dermal circulation. We want to close a big raw area, then there should be flow to the derms. The oximeter is more than 60 mm mercury, then the skin will not viable. There's only indication where you should not switch it up. You leave it over, right?
Okay, sir.
What is Rutherford category 5?
So it is major tissue loss, sir. Some minor tissue loss, sir.
What's the reason in your case?
It is a
Patient had other three toes are viable, fifth and first are lost. What could the cause?
So usually arterial disease usually affects the most common on the little and the great toes and on over the pressure areas, sir.
In other words, what are the angiosomes present in the foot?
Yes, so the 6 angiosomes are present. One on the posterior tibial, sir. Sorry, one on anterior tibial. There's dorsalis pedis artery, sir, and then 3 on the posterior tibial, medial and lateral plantar, and medial calcaneum, and one on the peroneal, which is 2 on the peroneal, which is medial lateral calcaneum, and anterior perforating branch, sir.
So when you see a gangrenous toe, what does it mean clinically? The disease already crosses the popliteal artery, but there is a there is a collaterals are developed, right?
Yes, sir.
So now tell me, what are the collaterals around the knee joint?
Collaterals are on that joint. Collaterals are formed by
There is so when there is a
deep
body reacts, they develop a collaterals, right?
Yes,
Then
sir.
you must know. Go ahead.
Okay, Dr. Malini, now that they
Yes,
were
sir.
asking you about the arteries to the lower limb, do you know what are angiosomes?
Angiosomes are tissue blocks, so the three-dimensional tissue blocks supplied by a specific artery along with a vein.
Very good, very good. So how many angiosomes are there in the foot?
So there are 6 angiosomes, sir.
There are 3 angiosomes consisting of?
Consist of 6
What are the-
branches. Sorry, sir.
Yeah, what are the primary 3?
That is dorsalis pedis, sorry, sir, anterior tibial, posterior tibial, and peroneal, sir.
Very good, very good. Now posterior tibial has all those medial and lateral calcaneum.
Yes, posterior
So
has
your
medial,
patient has,
lateral, and
right,
medial
right.
calcaneum.
Your
Yes.
patient has blackening of the great toe and the fifth toe.
Yes,
So
sir.
which angiosomes are involved now? Which
So then
arterial thing is involved?
dorsalis pedis, sir.
Dorsalis pedis, okay, more important.
Here, dorsalis pedis and calcaneum branch of, so lateral calcaneum
Medial and
branch of
lateral,
the, sir,
plantar arteries. Medial and lateral, that is the posterior tibial.
posterior
So
tibial.
you
Yes,
have
sir.
the anterior dorsalis pedis is a continuation of anterior tibial.
So sorry,
Dorsalis
sir.
pedis. Dorsalis pedis is a continuation of,
Anterior tibial, sir.
right. So you have the anterior tibial involved, you have the posterior tibial involved. And
Yes,
for
sir.
the little toe,
That is lateral calcaneum branch, no, sir.
yes.
Yes, sir.
So
That is peroneal, sir. Peroneal.
so all three vessels are involved here now,
Yes, sir.
right?
Yes, sir.
Good.
Yes, sir.
Now what do you do?
For this patient, I would first optimize the patient, sir. I would like to go for a basic blood investigation for this patient. Sir?
Yeah, of course.
Yeah, yeah, sir.
What
Sir, I would go
what
for a CBC, sir, to rule out, to find if the patient is anemic, or to rule out if the patient has got polycythemia, as it is an important risk factor. And then I would also evaluate RFT for this patient, because in future, if needed, I would go for CT angio, sir. So for before putting contrast, I would like to verify if the
is
RFT
diabetic?
value. Yeah,
First
sir.
of all, is
Diabetic,
diabetic.
hypertensive,
Is diabetic,
atherosclerosis.
sir.
So
Yeah,
will you not
diabetic. So
do a
you have
Sir,
to go and evaluate his diabetes first of all, instead of going for his PCV and all that kind of thing.
next, sir, next I'll go for is HbA1c with the fasting and postprandial blood sugars.
lipid
He's not
profile?
taking any medicine in your medical history. What medicine is he taking?
Metformin, sir.
Have you mentioned that?
On OH, I've mentioned he is on OHA, sir. I've not mentioned the medicine name, but I've mentioned this as the patient is taking 20 years diabetic and he is on OHAs.
Okay.
Lipid
So
profile,
20
ma?
years. Sorry.
Sorry,
Will you
sir.
not do a lipid profile?
Yeah, sir. Lipid profile is also yes, sir. I will. Yes, sir. I'll do lipid profile also, sir.
Yeah, lipid profile. Then you do a RFT.
Okay, sir.
So you have to control the hypertension, control the hypercholesterolemia, control diabetes.
Yes, sir. Control diabetes, hypertension. I mean,
So you do a
hypercholesterol.
serum creatinine for what you do.
Because so before putting contrast, sir.
No.
Suppose the
Diabetics
serum
are
creatinine is high.
Ah, yes, sir.
The
Yes, sir.
serum
That is
creatinine,
also yes, sir. Serum creatinine will be high in a long-standing diabetic patient, sir.
if serum creatinine is high, how do you take a CECT?
Sir, I would go for non-contrast MRI.
What is it?
Gadolinium, sir.
No, you can do a carbon dioxide.
Carbon dioxide also, yes, sir. Carbon dioxide angiogram, sir.
Okay, Dr. Malini, I'll just ask you one
Yes.
question. Very
Yes,
popular
sir.
these days. Is there any drug you can give before you do a CCT in a patient with compromised kidney?
Any drug? So any drug to treat what, sir? For RFT or?
No, you give
No,
a drug is given these days in a
Okay, sir.
patient if you want to do a CCT and
N
has
N
a compromised kidney.
NAC, sir. NAC, sir.
What?
Yeah,
Yes,
N-acetylcysteine, sir.
Yes,
Yes, sir.
N-acetylcysteine is given these days.
Yes, sir.
Very good,
Thank you.
right? That's the
Yes, sir.
drug, right? I'm so happy you know this. Okay, yeah. What was I asking? Anyway, go on, sir, please. Anyway, I just forgot. So diabetes. I'm sorry. Patient with diabetes, you must get his eyes tested, right?
Yes, sir. Retinopathy, sir. Or
Yes, and you must get his kidney tested. You must get his heart tested.
nephropathy. Yes, sir. Yes, sir. Yes.
All these tests have to be done.
Yes. Yes, sir. Yes, sir.
Right. So anyone? Okay. Now what do you do about this?
Kanna sir was asking. Kanna sir, please.
What is your plan of treatment in this patient? What is number 1, number 2, number 3? How do you plan that?
Okay, sir. First is that if the intervention is planned, I would go for a CT angio, sir, for this patient. First, Doppler, because the patient already has gangrene. It's better. I think it's better to go for CT angio rather than Doppler scan, sir. But
So
Doppler can be done
before,
initially, sir. In my college, I would prefer taking a arterial Doppler.
no, that has to be first, है ना?
Yes,
You
sir.
cannot go for directly for the angiography. No? You have to do the Doppler,
Yes, sir.
and then
Yes,
if
sir.
needed, you know, if you
Yes,
are
sir.
planning for some active treatment, then you will go for the angiography. Yes.
Yes, sir. Yes, sir.
So when you are doing the Doppler for this artery, what is the frequency of the probe which is used?
7 to 10 hertz, sir.
Megahertz. Huh?
Megahertz, yes, sir. 7 to 10 megahertz.
Yeah. Okay. And how do you hear the arterial sound and how do you hear the venous sound?
Arterial sound is push, sir.
Yes.
And
And
venous is hum, sir.
venous is hum. Yes.
Yes, sir.
Right.
Yes.
Okay. So when you're doing the Doppler studies, what are the things you want to see?
So I would like to see the flow. So in Doppler, we have to see the flow of the blood flow of the arteries, sir.
You're only looking for the
So
blood
blood,
flow
then the
only?
location, so sir, the location of the stenosis, I mean, wherever is the lesion is,
Yes.
can be obtained from that, sir. Depth.
But it is always a duplex scan, है ना? Because you have to combine both. It's a duplex scan.
Yes, sir, duplex
Whenever
scan.
you,
Yes.
when you are carrying out. So you have to look for both anatomy and the physiology.
Physio, it's a lumen as well as the blood flow, sir.
Yes. Okay. So
Okay, I'll just ask
when,
you a tough one, Dr. Malini.
Yes, sir.
So please,
yeah, please
Dr.
carry on.
Malini, have you heard of Wi-Fi and glass?
Yes, sir. Wi-Fi and glass are the Wi-Fi is for diabetic wound management, which predicts the amputation risk and the outcome of revascularization, sir. It
What is
is
Wi-Fi?
wound
What is
wound ischemia, foot infection, and
yes
yes, sir.
glass?
And glass,
Glass is
global.
sir, 1 second, sir.
Global limb
Global
Okay, so
anatomy.
global limb anatomic staging system, sir.
excellent. Malini, you've
Excellent.
got 110% today from me.
Yes, sir.
Yes,
Yeah.
okay.
There's one more thing called task. Do you know what is
Task,
task?
yes, sir.
Yes.
1 second, sir. Give me some time.
Atlantic,
Sir?
transatlantic.
Transatlantic consonant, something transatlantic inter-society consonant, sir.
This is
Transatlantic.
task 2 force task guidelines. Right?
It is
Transatlantic
for
Inter-Society Consensus. It
sir.
is Transatlantic Inter-Society Consensus.
City
Task
consequences.
guidelines.
Yes, sir. Transatlantic
So
inter-society consequences. It is for iliac and
no.
femoropopulative.
It tells you whether you can do an endovascular
Endovascular or bypass grafting can.
Or
Yes, sir. A,
right?
B, C, D, sir. And
Right.
A and B mostly endovascular technique. C and D, D is bypass grafting, sir. C is either you go for endovascular or bypass.
Very good.
Yes, sir.
It add another 10% to your 110%.
Thank you.
good.
Right.
What are the different types of the task?
Different different tasks, sir.
Yeah.
It is for iliac, femoropopiliteal. It is about the segment involved, sir. Measuring of in iliac, A is less than 3, B is 3 to 10.
Dr. Malini, I'll just intervene.
Yes, sir.
Look, you're doing so well. You just have to remember it has to be the size of the length of the thrombus.
Sir, sorry,
right?
sir.
The
Yes, the length of the thrombus. Yes, sir.
Right. The number of thrombus.
Lesions. Lesions, length of the thrombus. Yes, sir.
And whether it is involving the tributaries or not. three things you have to take in factor.
Yes,
Right?
sir. Yes, sir.
And that's how you decide task A, B, C, and D.
Yes, sir.
Right.
So when you are doing the angiography for these patients, what are the things you want to see in the angio? Have you done the angiogram in this patient?
Yes, sir. I've done the angiogram, but it has come today only, so I have not uploaded it. We just received it, sir. Yes, sir.
Okay.
Should I show you, sir? Or?
Yeah, what are the things you want to see on angiography?
But you can
And
read
then-
the report.
And then
Not the report. I've got just the film, sir. It has to be reported, sir.
Okay, Dr. Malini,
Yes, sir.
I'll ask another tough one. What is the classification used for angiography?
Geographic classification.
What is the scoring system? It's called Bollinger scoring system. Okay?
Sir?
Bollinger scoring system.
Sorry, sir. I don't know, sir. Sorry.
Yeah. So I know good. So it has, they take 4-5 things into one is location,
Okay, sir.
whether it's single or multiple,
Okay, sir.
whether it's less than 50% of segment or more than 50% of the segment,
Okay, sir.
right? And
Okay, sir.
it sees whether the occlusion is complete or incomplete.
So could you please repeat the name of it, sir?
We'll pick it up. You can't do it.
Bollinger, Bollinger.
Bollinger.
Okay, sir. Okay, sir. Got it.
Bollinger scoring system, right? Okay.
Yes, sir.
okay, so what are the things you are going to see in the angio?
Sir?
What things you are going to see in the angiography?
Depth, sir. The segment involved, and then composition of the plaque. Am I right, sir?
The most important thing which you see is
Level, sir. Level
level
and sir.
distal
Color-
runoff.
Distal runoff, yes, sir. Distal runoff.
So that is the most important thing that
Yes,
you
sir.
see
Yes,
for
sir.
the
Why is distal runoff most important? Sir said distal
So
runoff.
it
Why
is important for the surgery, sir. If angioplasty has to be bypass grafting as planned, it plays a vital role, sir. It cannot be done if
right.
it is not necessary.
If you bypass the obstruction and still there's no flow, then there's
Yes,
no
sir.
fun of doing it. Exactly.
Yes, sir. There's no point in doing it. Yes, sir.
Here, can you have a distal runoff?
Yes,
Is it
sir.
the tip
Here
of
we
it?
can. Yes, sir. Collaterals would have found by now, sir.
The
Okay,
tip
you
of
said
it
collaterals
goes.
are formed. What is disappearing pulse?
Disappearing is pulses. The patient with the arterial disease will have pulse because of collateral formation, sir. And when the patient is when the muscle is put into work, the pulse disappears, sir. So it unmasks the arterial obstruction, sir.
Malini, you're brilliant.
Thank you, sir.
Test.
The Bollinger score is 0 means 0% block normal artery. Okay.
Okay, sir.
Point
Okay,
one,
sir.
1 is 1 to 19%, 2 is 20 to 49, and 3 is 50 to 99, and 4 is 100% block. That's Bollinger scoring system of
Okay, sir.
angiogram.
Angiogram, yes, sir.
So what is the further treatment for this patient?
So depending upon the CT, sir, already, sir, first of all, the great and the first little toe has already been gangrenous, sir.
First thing, you have to relieve the pain of the patient. That is the most
Yeah,
important
most
thing.
important, yes, sir.
What are the
And
conservative
then,
lines, ma?
Pain management plays a vital role, sir. With the non-opioids, weak opioids and strong opioids, we can categorize it and give to the patient. So if it doesn't respond to the
No, Dr. Mani, that's not the pain ladder. Tell me the WHO pain ladder clearly, correctly.
So first is the non-opioid, sir.
No, it is paracetamol.
Yes, paracetamol, brufen,
NSAIDs.
NSAIDs, yes, sir.
Third, synthetic opioids.
Okay, sir.
Fourth, opioids.
Opioids, okay, sir.
Okay, Dr. Malini, I just forgot. I wanted to tell you, missed something very important. Is there any smell?
No.
odor. We have not
No,
mentioned
sir.
it anywhere.
Yes,
Why?
sir.
Is this a wet gangrene or a dry gangrene? Now, let's come to
It is
that. We've
it
not.
is dry gangrene, sir.
What is the difference between wet and dry gangrene?
Sir,
Look,
in the wet,
in
in dry,
examination, Dr.
sir.
Malini,
Yes, sir.
in your examination, you have not tried to elicit whether it's wet gangrene or dry gangrene.
She
Okay,
had
sir.
mentioned no discharge.
No, yes,
No
sir.
discharge, no edema. You told, I think.
Yes,
One
sir.
slide.
I've mentioned
But
about
that's
this.
not
No,
edema.
also.
Edema is fine. Edema can be there in both. Proximal edema can be there.
Okay, sir.
Smell,
No discharge,
line
you
of
said. I think
demarcation,
so.
Yes, sir.
hypersensitivity at the line of demarcation,
Yes, sir.
skip lesions. These are very important features here, which has been missed because
Yes,
if
sir.
there are skip lesions, you'll not be doing anything immediately,
Okay, sir.
right? So all this is missing in your examination.
Presentation. Yes, sir.
Right. So please. So what's the difference in dry and wet gangrene?
Sir, dry gangrene is there'll be line of demarcation, sir. In wet gangrene,
What is
there'll
that
be
line? Why is that line of demarcation in dry gangrene? Why is
because
there line of demarcation?
yes, sir. It is between the dead and the viable tissue, sir. A band of hyperesthesia and hyperemia between the dead and the viable tissue is the line of demarcation. It occurs when the arterial blood supply is insufficient.
So it happens because at the line of demarcation, the nerves tend to are trying to go into the tissue.
Yes, sir.
So they are bare nerves, so there is hyperesthesia.
Okay, sir.
There's neoangiogenesis.
Yes,
The
sir.
blood vessels are trying to penetrate into the dead tissue.
Yes, sir.
So there is hyperemia.
Okay, sir.
Right?
Yes, sir.
So these are the two, and there is no odor.
No,
There's
yes, sir. No discharge. Yes, sir.
no putrefaction. Discharge can be there.
Okay, sir. No putrefaction, no discharge. Okay.
Right.
Yes, sir.
What about wet gangrene?
Wet gangrene, super added infection, sir. There'll be foul smelling discharge will be present. The line of demarcation cannot be appreciated.
Right.
And
And
wet gangrene is an emergent, sir.
There will be skip lesions.
Skip lesions, yes.
What is
When
the
do you
importance
get
of Sorry, go please.
When do you get the dry gangrene and when do you get the wet gangrene?
Yes, sir. Dry gangrene occurs usually when the arterial blood supply is diminished. Wet gangrene commonly occurs in superadded infection. Sorry, infection, sir. Infectious place or diabetes.
Look, dry gangrene is what? The tap is being shut off slowly.
Yes, sir.
Right?
In acute embolism.
Acute meaning. Shut off slowly. The thrombus is growing and the thing is shutting off. The blood supply is shut off slowly. So it gets fills, it shrinks.
If both the artery and veins are blocked at the same time, what type of the gangrene will be there? Both the artery and vein are blocked.
Okay, sir.
What type of the gangrene you will get?
Gangrene. Sorry, sir.
It will be wet gangrene, you know?
Wet gangrene. Okay, sir.
Okay, both the artery and veins are
Okay,
simultaneously blocked there.
Okay.
Okay. So again, go for your treatment. You have tried for the pain.
Yes, sir.
You have tried for the control of the diabetes. How will you control the diabetes in this patient?
Sir, I'll look for FPS, PPPS, and HbA1c, and low carbohydrate diet.
So do you want to control the diabetes here by the oral?
No, sir, I'll switch on to insulin, sir.
No, you have to switch to the
Injectables, sir.
insulin.
Injectables, yes, sir.
And what type of the insulin? Long acting or short acting?
No, long acting, sir.
Short acting. Okay, because you have to, because these patients are very likely to go into the hypoglycemia.
Okay, sir.
Okay, because the infection. So that is why it's a very brittle type of diabetes is there. And that is why you have to have the short action so that you can give the patient. Yeah.
Yes.
Okay.
Yes, sir.
So then after the diabetes, what next comes? You have to control the infection.
Yes, sir. If it is infected, we'll start him on IV antibiotics.
Give the patient the IV antibiotics. Yeah. What other things can be given? What are the other medicines which can be given for the
Sir, antiplatelets
ischemia?
and antiplatelets,
Which antiplatelet you will use?
aspirin, sir, 75 milligram or 100 milligram.
Usually dual antiplatelet.
Dual antiplatelet is with along with the clopidogrel also, sir.
Around the clock. Good.
Dual platelet therapy, yes, sir.
Then any
And
other?
now we can also start him on anticoagulant, sir.
No, Dr. Malini. Dr. Malini.
Yes, sir.
What is the difference between a venous thrombus and arterial thrombus in management?
In management.
Or difference? Or difference? What is the difference venous thrombus and arterial thrombus?
Okay.
You said anticoagulants. That's why I asked you.
Yes, sir.
Do you put an arterial thrombus onto anticoagulants?
Yes, sir.
Where do you put anticoagulants? You put them on in venous, in DVT, or in arterial thrombus?
Mostly on
Arterial
the
thrombus is because of what?
sir.
Arterial thrombosis is because of what? Arterial
Atherosclerosis.
thrombosis. It is because of platelet problem.
Yes, sir.
That is why you put antiplatelets, clopidogrel, aspirin.
Aspirin, yes,
These
sir.
are the things, right?
Yes, sir. Yes, sir.
In DVT,
Yes, sir.
it's a venous thrombus.
Venous
It is a
thrombus, okay.
coagulation problem.
Coagulant, yes, sir.
So you put them on anticoagulants.
Yes, sir. Okay, sir.
Venous thrombus is called red thrombus,
Okay, sir.
right? Because it contains red blood cells.
Okay, sir.
Arterial thrombus is called a white thrombus
Okay, sir.
because it contains platelets,
Okay, sir.
fibrin.
Fibrin, yes, sir. Correct, sir.
No, I think
Now
nowadays, doctors are
yeah, they
nowadays
do. I'm sorry. They do.
anticoagulants
They
are
do that. They do that.
anticoagulations are given, but in the
Yeah.
low dose, like
Yes.
rivaroxaban is there.
Correct, sir. 2 point.
Not,
Sir, can I ask a doubt, sir?
yeah.
There is something called as dual platelet inhibition therapy.
Yes. What
Where
is that?
so that's what I've studied. I've told sir, but I don't know if I'm wrong. There we have in order to reduce major adverse cardiac events and major adverse limb events, the low dose anticoagulants are also being added. That's what I studied,
Yes.
sir. I don't know if I'm right or wrong.
Yes. That's right. I was coming to that. Low dose anticoagulants is given to
Yes, sir.
prevent the sequelae of the platelet action, platelet
Okay.
clumping.
Okay, sir.
But the dose here is low, like
2.5
normally
milligrams.
it's only 2.5 milligram twice a day it is given.
Yes,
While
sir.
when you are doing it for the DVT, then
Sir.
dose is there 10 to
10
15 or 20
milligram.
milligrams.
10. Yes, sir. Okay, sir. Got it, sir. Thank
So
you, sir.
warfarin has no role in arterial thrombus.
Okay,
It
sir.
has a big role in venous thrombus.
Okay, sir.
Right.
Okay. Any other medicines you want to give?
Globulate.
For a critical ischemia? Because this is a case of critical ischemia.
Prostaglandin.
Yeah, prostaglandin
Prostaglandin
can be given.
analogs. Okay, sir. Alprostin, sir.
Yeah, that's right. That can be given.
Yes,
And
sir. Yes, sir.
immunoglobulins are there. Immunoglobulins are given.
Okay, sir.
So all these drugs can be used for that.
Yes, sir.
So are you going to amputate the limb or not?
I will try to save the limb, sir.
Okay. So how will you save the limb?
So depending upon the segment and the lesion involved in the CT angio, sir.
Yeah, what does the CT angio shows here?
Here in the film it shows femoral-popliteal occlusion only, sir.
And what about the distal runoff?
Distal
Is
runoff
there
clear,
or
sir.
not?
Distal runoff clear, sir.
It's clear. Okay. So then in that case, what you can do?
So if the segment is short segment is involved, I go for endovascular therapy.
Right.
Long segment involved, I go for bypass grafting, sir.
Mhm. Okay. So what is in your case? Is it a short segment or a long segment?
That report yet to be reported, sir. But
Anyway, so what are the various ways of going for the open surgery for these patients?
open surgery, sir.
Yeah. What are the various techniques which you can do?
Seldinger techniques.
Seldinger technique is for the endovascular. Right?
Angiogramas is open technique is
You know, there's a block is there, big block is there.
yes, sir.
So you have to bypass that.
But grafting done.
Yeah.
Grafting, sir. Bypass grafting, sir.
So which graft you would use?
I'll use great saphenous vein, sir.
Great surface vein.
Reverse or in situ.
Right. Because you can either use the PTFE graft.
If
Or
the first preference is great saphenous, sir. If not, then I go for synthetic, sir, which is PTFA or Dacron, sir. Knitted or woven.
why do you prefer the GSP?
GSV is
saphenous
preferred
vein?
because less infection, longer patency, less graft failure, sir.
What is in situ grafting?
In situ is we will not reverse the vein, sir. It will be in the place and we will do valvotome where the valves are alone destroyed, sir.
Sai, you want to ask any question?
No, I think she's exhausted
She
my
is.
question. Very good.
Sarah's already
Exceptional.
given her 110 marks.
Yeah, she's exceptionally
You're
good.
done. You're done well, ma. Congrats, sir. Convey my
Thank
regards
you.
to RSS. RSS, sir.
Malini,
Yes,
my
sir.
point.
Special thanks to
Please,
RSS,
sir.
sir.
One week for the gangrene dose.
Yes, sir.
You said there's a gangrene. What will you do for that?
Yeah, what will you do for the
That has to
gangrenous?
be amputated, sir. Those 2 toes, I think it has to be amputated because it is irreversible, sir. That goes for amputation.
At
Right.
what
But
level,
discoloration was extending up to the four
you said
foot, isn't it?
Yes, sir.
The discoloration extending up to the 4 foot.
But
So would
but
you
we
like
can
to go
wait for
next?
this. Sir, it has not turned into complete gangrene, sir. So we can wait for revascularization after technique. If it is improved, I think we can wait for that, sir.
Just say, Dr. Malini, that I'll wait for the line of demarcation to happen.
Okay, sir. We'll wait for the line of demarcation.
That's the answer I
Yes,
was expecting.
Okay,
yes,
I've
sir.
got one question for you.
Yes, sir.
What is the difference between necrosis and gangrene?
Necrosis is macroscopic. Sorry, sir. Gangrene is macroscopic death of tissue, sir. Necrosis is microscopic, sir.
Yeah,
Microscopic death of tissue, sir.
right. Good.
Yes, sir.
Then what is apoptosis?
Apoptosis. Yes. Autocell death, sir. Sorry, sir.
Read. You can read it.
Yes,
You're good in reading, so you read it. Okay.
yes, sir.
Yes.
Malini, so you're talking about all the angioplasties, right? What's the
Yes.
basic request to think of angioplasty?
So what is the basic?
Request to think of an angioplasty in vascular disease.
So sorry, sir. I'm not able to get you, sir.
So you are talking about the angioplasty, right? In
Yes, sir.
peripheral disease, what is the prerequisite to think of angioplasty? There has to be some
Distal run off.
there has to be a distal run up and there will be active muscles.
Muscles. Okay, sir.
Only think of this. A dead tissue, don't think.
Think of, yes, sir.
Vessels are gone.
Yes,
So
sir.
you cannot preserve the gangrenous dose, right?
Okay, yes, sir.
Never there's a never say you'll go for a angioplasty, right?
Okay, sir.
And one more point, that is
One
calcium
more
scoring.
question. You have so far done a very well.
Okay.
There are, see, when the veins are dilated, we say it's a varicose vein, right?
Yes, sir.
When the arteries are dilated, what is called?
Aneurysms.
No. When the veins are dilated, we call it a varicose vein.
Yes, sir.
When the arteries are dilated, what is called? Arteria
And,
Magnus syndrome. Have you heard of it? Arteria Magnus syndrome. Those
sir,
were
sorry, sir.
stories were aneurysm, right?
Aneurysm,
So,
Okay.
and this add to your PT, right? So far you have done very well. So
Okay, sir.
sometimes there were some abnormal things, right? Then you have
Yes,
to
sir.
also think of that.
Okay, sir.
Okay.
Okay,
Very
Dr.
good.
Malini, I'll just ask you one question. So I asked you
Okay, sir.
what is an arterial dilatation called?
I told it as aneurysm, sir, or ectasia, sir.
Aneurysm is right, or ectasia. Now, what's the difference
Yes, sir.
between ectasia and aneurysm?
Aneurysm is 50%. When 50% dilatation occurs, it is aneurysm. Less than 50% is ectasia, sir.
Very good. Right? And if it's aneurysm is in a certain area, ectasia is involving a larger area,
Okay, sir.
larger section.
Okay, sir.
Good.
Only in your patient, you can also use a very good candidate for stem cell.
Stem cell.
So you can get the stem cell therapy in this patient.
Okay,
for the,
sir.
yeah.
Okay, sir.
Mhm.
To put in pleural. Okay, sir.
Yeah,
Just
Malini, well
one
done.
point.
Yes, sir,
Excellent,
please.
excellent, sir. Excellent. Just one point I wanted to add is, sir was asking the prerequisites for the angioplasty. So there is importance of calcium scoring. If the vessels is highly calcified, then you cannot
Calcified?
go
Yes,
for
sir.
it.
Yes, sir. Yes, sir. So as
Just
so
one
in
point.
diabetic patients, sir. Yes, sir.
Yeah, yeah. Yes, you have done exceedingly well. Very good.
Very good,
Thank you.
Malini. I have to
Thank you.
congratulate Professor Hassan.
Yes, sir.
Very good.
Yes, sir.
Yeah, regards to RSS Sarma.
Yes, sir. I'll also use this platform to thank my sir, sir.
Yeah,
Thanks
thank
to
you.
my professors. Yes, sir.
Kanna
Well
sir,
done,
any
Malini.
closing comments?
Sir?
Kanna sir,
I
I
closing
said, well done,
comments.
Malini, you've done well.
Yeah.
Nothing, you can't add it.
I
Yeah,
think
but some basics are missing. Some basics are missing, which I would like you to incorporate.
Add in the list.
Yeah.
Yes, sir.
I think nothing to
Thank you.
say. She has done exceptionally good.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Kanagavel sir. Kanagavel sir, can we close?
I think he's not there. We can close, sir. Thank you so much, everyone.
Okay.
Thank you,
Suraj and
sir.
Malini for your
Thank you.
presentation. Keep developing. God bless you all.
Thank you
Thank
so
you,
much,
sir.
sir. Yes, sir. Thank you. Thank you, sir.
Bye-bye.
Okay, good night.
Good night, sir.
Good night.
Good night. Good night. Thank you. Thank you all, sir.
Thank you, sir. Thank you, sir. Yes, sir.
Make the stop பண்ணுங்க.
எல்லாரும் சொன்னீங்க.
Stop பண்ணுங்க.
எப்படி கேட்க?
Mute கொடுத்துருங்க.
Dr. Malini, you can unshare the screen.